Hello there. Thanks for choosing to watch this presentation. I'm going to be talking about multimorbidity in primary care before and during the COVID-19 pandemic. So overall, our research aims to try to understand the healthcare needs of those with 2 or more long-term conditions, usually referred to as multimorbidity. As part of this research, we've been looking at which combinations of long-term conditions are associated with the highest primary care use, and that's something I presented last year at HSR UK. We've also been looking into the referral rates from primary to secondary care, but more relevant to today's presentation. We have been identifying combinations of long-term conditions that drive primary care costs of individuals with multimorbidity, and also, of course, assessing how the pandemic may have influenced primary care demand for those with multimorbidity. So this figure shows primary care consultation trends for individuals with multimorbidity, which is the orange line, and those without multimorbidity, which is the blue line. So the prevalence of multimorbidity in our sample is about 20 to 25%. However, as you can see, their total primary care consultations are consistently higher. So basically, when you adjust the two groups for their size, those with multimorbidity and those without, you basically see that the first group, the multimorbid sample, uses primary care between 3 and 4 times more than those without multimorbidity. And this gap is actually pretty consistent over time. So our research tries to understand this differential by looking at the drivers of health service use and costs. And within the multimorbid group, we know that not all these combinations drive health service use in the same way. So we basically look for what these high users may be as well. So today, first, I will be talking about these high use, high cost individuals with multimorbidity that largely drive health service use. And second, I will then present on how the pandemic affected overall primary care use by individuals with multimorbidity. So turning to the first research question on multimorbidity and primary care costs before the pandemic. Basically, we had a couple of research aims. First, we wanted to identify long-term conditions with a major contribution to primary care costs, and then focus on the high end of the primary care cost distribution of individuals with multimorbidity and try to characterize this group, basically assess whether this group has some common LTC clusters or not. To achieve that, we used a sample of adults registered to actually 41 practices in South London in 2020. Looking at the second aim and just clarifying for a second what we mean by high cost individuals, we looked at the distribution of primary care costs and identified the 80th percentile, and we define high cost as those with costs placed basically on the top 20th quintile or above basically. And that was our high cost definition, and that's based on this idea of cost disproportionality, which is that is, you can say that the group has cost disproportionality if the percentage of the population that they account for is actually smaller than the percentage of the resources that they use. So our outcome of interest in both cases for both study aims were individual level primary care costs, which we generated by multiplying the different types of primary care consultations by unit costs. These are standardized and publicly available. And regarding our statistical techniques, we started with some descriptive analysis to address aim 1, and then we moved to some latent class analysis to look at clustering among high cost groups. So moving on to the results of the first study aim, what we see is that individuals with multimorbidity had slightly above 13,000 unique long-term conditions combinations in 2020. And here in this table, you can see the top 10 combinations sorted by the percentage of primary care cost that they represent. So for example, you can see at the very top, the combination of anxiety, chronic pain, and depression. It was suffered by around 6,000 individuals in our sample, and it had the highest contribution to total primary care cost, and that corresponded to slightly above 5%. So based on this, we conclude that no single combination accounts for a sizable proportion of total primary care costs. You may be noticing, though, that several of these 10 combinations actually include mental health conditions, anxiety and depression, which are in red font. So we actually looked at how much those account of total primary care cost, and we see that long-term conditions combinations that contain anxiety and depression represent 31% of primary care costs. So now turning to the results for the second study aim on high-cost individuals and clustering, we even see more heterogeneity in this group. So we see close to 7,000 unique long-term conditions combinations, which is actually nearly 3 times more heterogeneity in terms of combinations of long-term conditions among this high-cost group compared to the non-high-cost group once you adjust for their size. So what you can see now, this table summarizes the key characteristics of the 5 clusters that we found were the best way to group high-cost individuals with multimorbidity. You can see each cluster in a separate column, and then the rows aim to describe these clusters. So what you can see is the sample size, also the prevalence of the individual long-term conditions, and then what would be the third row is the most prevalent long-term conditions combination. And what we see is that individual combinations of long-term conditions did not dominate clusters, except for cluster 1, that, as you can see, 15% of individuals had anxiety, chronic pain, and depression. So overall, key takeaways from this piece of research. The first one, the importance of mental health as a cost contributor, and secondly, the high heterogeneity of individuals with multimorbidity, and particularly among high-cost individuals. Okay, so now we're moving on to the second part of this presentation, which is looking at multimorbidity since the onset of the pandemic and trying to understand impacts in terms of primary care use. So our research aim was basically to analyze the effect of COVID-19 on primary care consultations among those with multimorbidity. We used again the Lambeth DataNet, but we focused on data starting in February 2018 until March 2021, and we consider March 2020 as the start of the pandemic. Our outcomes of interest were consultation rates, and we look at total and also by provider types, which you can see listed in the slide. And we started by just generating some overall descriptive analysis on trends for these outcomes before moving to a formal analysis of the impact using interrupted time series analysis. So these are the results. What we see in terms of first descriptive statistics is that between 2020 and 2021, primary care consultations overall increased by 17%. So there's this kind of upward trend. But if we look specifically at the period during the pandemic, total primary care consultations were 15% lower in April 2020 when compared to the previous year. And specifically, what we observe is that after this initial drop, an upward trend is observed in total consultations. And actually, in February then, the February baseline is then surpassed in June 2020. So that's when kind of they fully recover after the initial shock. And here is the title of the figure. We had missed that one. So I think it's also pretty interesting to look at what happened by types of primary care consultations. And this is what this figure on a slide shows you. What we see is that the composition of delivery mode really changed with telephone consultations being used more frequently. And then more generally, there was a shift, right? We're seeing how the two lines kind of cross for the telephone and face-to-face consultations. Face-to-face consultations made up 75% of consultations and telephone 24% in February 2020, so before the pandemic. And that had changed to 53 and 43% respectively in March 2021. So now turning to the more refined analysis where we look for kind of differential effects in total primary care consultations between those with multimorbidity and without. What we see overall is that primary care consultations of individuals with multimorbidity experience a smaller drop in 2020 compared with those without multimorbidity, but they seem to recover a bit more slowly. And for that, I think it's quite interesting to compare what was happening to the overall level of the trend for those with multimorbidity and also their slope, and compare that to those without multimorbidity and see the impact of COVID on both. So what we see is among those with multimorbidity, the level of the trend line, this kind of initial drop, was 47% compared to 65% among those without multimorbidity. But then the slope of the trend line after that experienced a 2% increase in the growth rate among those with multimorbidity, while slightly larger 4% among those without. In terms of the strengths and limitations of this work, the main strength is that we use a large longitudinal data set with several clinical and sociodemographic characteristics reflecting health service use patterns of an ethnically diverse population. Some limitations include also, on the other side, that results may not generalize to other populations that are a bit less urban or less deprived. We only assess primary care consultations, right? What else happened to secondary and tertiary care during the pandemic and even among high-cost individuals? And we also consider that, it's very important to assess exactly this relationship between face-to-face consultations and telephone consultations, where they're substituting each other or where telephone consultations just the initial point of care, and then as a follow-up there were even more telephone consultations, even a face-to-face. So further work into understanding changes in the care pathway of individuals with multimorbidity in primary care is also important to further assess. To sum up some concluding thoughts, COVID-19 caused an initial contraction of primary care demand, but we actually see that it was smaller among individuals with multimorbidity. We want to also consider that this effect actually, based on what we have learned, right, that individuals with multimorbidity, it's a label that we use, but this group is really heterogeneous. Like almost each patient seems to be unique in terms of the different combinations of long-term conditions and the severity of those conditions. So we should be careful when thinking about, it seems like this group was in theory less affected by this initial shock of the pandemic. Well, it's unclear. And there may be subgroups, and we're beginning to explore that the effects of the pandemic may have been magnified for both in terms of the combinations of conditions, but even within the multimorbid group, at different ethnic groups. And we're at the moment developing a paper looking at that. We think it's very important to conduct also further research into the consequences of this initial shock. So what happened in terms of possible late or misdiagnosis, And then also, as I was saying before, as one of our limitations, we're really looking forward to linking primary care data to at least secondary care data to get really the full picture of what happened both before and during the pandemic to individuals with multimorbidity. And with that, we reach the end of my